Whoever speaks English, please, we have translation.
So you can go for the headphones. La sesión que vamos a
The session that we're going to have right now, it's about the strengthening of the cold chain and lessons learned during the COVID-19 pandemic. The panelists, we have Thayssa Victer from the Ministry of Health. She's responsible of the cold chain of the immunization program of Brazil. We have Sandra Aparicio. She works in the Ministry of Health of Colombia. And Juan Pablo Rodríguez, the responsible and person in charge of the immunization program in the cold chain in Chile. A little bit about this session is that we see some lessons learned and different opportunities that we had in the pandemic. Nevertheless, these challenges that we had and the lessons learned truly gave a chance to the use of new technologies, innovations, so we could support and improve what the storage, distribution of the vaccines is. Also, routinary vaccines was considered in this expansion of the cold chain when we're talking about the distribution and storage. So I'm not talking only about COVID vaccines, but this opportunity of having the routine programs and considering the benefits that they were taking with them. Equally, when we expanded the cold chain, the capabilities of distribution and expansion and storage, we have a lot of vaccines ready to go. We have malaria, dengue, chikungunya, Zika, and others vaccines. So the countries right now have these capabilities in their cold chain for the expansion and the storage and the distribution of the vaccines. This is a great opportunity. Also, it gave the opportunity as Chile that has been working in the validation of different equipments that locally they have been surveilling and how they can validate this equipment so this can be stored and distributed within the norms of Chile for the storage and distribution of the vaccines. In the same way, we have the lessons learned and the opportunities in Brazil. And they have, in order to get to that last mile, that is the most important part, to get to the last mile of more than 5,000 municipalities that Brazil had in a department. So I believe that this is very important. This is what this session is about. Let's hear about their experiences of these three countries. I'll call to the floor Thayssa Victer. Thank you. Hi, good morning. I would truly appreciate PAHO and WHO for allowing me to participate in TechNet. Brazil it's a country with continental dimensions, different social context, economical and epidemiological internally. We have more than 200 million people, and we have different federal states. We have a superficie of a division in more than 5,000 municipalities. The national plan of operation of Vaccines Against COVID-19 was a document that was published periodically by the Ministry of Health from December 2020 to September 2022 that considered the strategies of immunization against the disease in the country. This document is called PNO, and it contained information about the evaluation of risk, the evaluation of priority groups, the updating of the denominators, the protocol of pharmacosurveillance, the indicators that we have of the campaign, an interval of doses, co-administration of vaccines, rapid response team, and vaccination strategies. Brazil adapted this strategy of vaccinating the priority groups with the most risk of hospitalization. These groups were amplified when we had more availability of dosages, like people with 90 years old and older, or people who were institutionalized, health workers, traditional country within our countries or tribes that are considered. The different criteria of distribution follow these principles. Priority populations defined in the document, objective groups per federation unit, depending on the doses that were available. It considered the vaccination schedule and their interval of 2 doses. We began in January 18, 2021, with the coronavirus vaccine that was from the company Sinovac. It will be simulated by Butantan in the Institute of Brazil. Then we had CoronaVac coming out again from Pfizer, and we have the recombinant Janssen. The one produced by Pfizer need to be stored in a super low temperature. Since 2021, we have distributed more than 656 million doses, and we have administered more than 536 million doses. Just in 2021, we distributed 390 million dosages of COVID. In 2022, we distributed 170 million dosages, and 2023, 89 million dosages, including bivalents. Our greatest provider has been Pfizer, then Fiocruz with AstraZeneca vaccine. We're talking about 330 million dosages in a super low temperature. You can imagine the magnitude of the challenge that Brazil has. We had different challenges in different regions that required more technical competency from the federal government to support the municipalities with the needs that they were facing. The main challenges that we found were bad infrastructure, domestic fridges, cold rooms that were insufficient for the capabilities that we needed for storage, to adapt the vaccination services in order to serve patients with COVID-19, instability of our energy, and we have a generator no break for the maintenance of our electrical network, and transportation of the vaccines that was inadequate. Nevertheless, we didn't have a logistic management system, so it was made very complicated, the collection of data in real time. Nevertheless, some places had technical teams that were very experienced and committed that arrived to systematize the information through the send of information and worksheets. We did exchange of knowledge and technical support amongst them. I decided to put an example here of a state that has one of the biggest challenges that you've ever seen. Amazonas state. It has an extension that it's huge, and it has low population. This is a big challenge for the logistic chain of the vaccines. Also, I have a lot of type of traditional, let's say, tribes. In the Amazonas, we have main transportation. We have aerial, we have maritime, and we have ground transportation. There are some images. I'll take this opportunity to thank and demonstrate all of the support of PAHO to Brazil to face these challenges. It was a donation with thermal boxes, delivery of syringes, needles, vaccines when we needed to augment the availability of dosages through COVAX or with the ministry. Also, they donated part of the ultra fridges that we used. Additionally to all of the technical support for the elaboration of our guidelines. I want to thank again to the WHO and PAHO for the invitation, our systems of health that truly work very hard to protect our population, especially the teams of the Ministry of Health that coordinated this whole process. Additionally, to the health of the state of Amazonas that I gave you the images of the information. And thank you so much for listening to me. Thank you so much, Thayssa. Excellent Spanish, not Portuñol. You tried really hard. Congratulations. Let's give the floor to Sandra Aparicio. Hi, good afternoon. Good morning, actually. It's so good to be sharing this experience with you. I work in the National Institute of Health in the area of epidemiological surveillance. And let me tell you, from this sector, the response that we had in Colombia to tackle the COVID-19 pandemic. First of all, I want to tell you about the national surveillance system in Colombia and how it works for our public health. We have providers of services that are in charge of notifying the cases, capture the cases, register them, and obviously notify them to the national surveillance team. We have 106 events of public health that are being surveilled, and a lot of them are immunopreventable. The municipality, the health center notifies the municipality, and then the municipality notifies the department, and then the department notifies the nation. Our health national institute needs to analyze information and disseminate it. This information is disseminated through an epidemiological national bulletin that is published on Fridays. Nevertheless, before the report, you do an analysis and a review of the information to check for quality. We have reports, not only the bulletin, but other instances like the Ministry of Health. When we're talking about measles, paralysis, and respiratory failure, we send information for to PAHO for these reports that are needed regionally for the bulletins, taking into consideration that these events are working towards the eradication and elimination. When we talk about our severe respiratory infection, we have a collective measure that captures the morbidity, the ER visits, hospitalization in intensive care units, and we have individual sentinel surveillance. This is two institutions that actually capture all of the cases and have the obligation to capture all of these responsibilities to capture the influenza and severe respiratory infection cases. They also do the analysis and the diagnosis to understand what is the viral circulation in the country. Here we have the deaths in children less than 5 years old. When we had COVID arriving, this strategy and it worked towards the surveillance of the sentinel surveillance. We didn't have those two institutions, but we have the whole country that could capture the cases and notify them to the system themselves. Afterwards, with the easiness of this system, we have a new technical notification because of a new virus or COVID-19. Up until here, we have the information of the epidemiological surveillance, the reference that we have in real time, achieved to standardize the technique for the diagnosis of SARS-CoV-2, but because of capability problems, it was difficult to do this transfer of knowledge throughout all of the laboratories and the universities that played a very important role in the diagnosis, and particular laboratories and all of the laboratories of the network of Colombia. What we had to do is to report the positive and negative results in different samples, and this is called cis muestras, and this is how we reported this. Considering the epidemiological information, we had a report nationally through a database that was called COVID-19 National Base Database. We made a cross-reference with the data that we had through the Soul Registry system to understand those cases that died because of COVID, and it was necessary to understand the hospitalized patients in the ICU or in the general rooms, and it was to understand also the entries and whenever a patient left the hospital. We had this open data with anonymous information for the patients, and it helped for investigation and research for the academia, and it truly helped to take away the need of information that each stakeholder wanted. Also, we had the daily report with some special characteristics. You know how many deaths we had and new cases and how much of them were in ICU. And for the territories, we had a division of the database for each of them in a way that you can have an intervention in each of those municipalities. In the same way, we had control dashboards that allowed the decision makers to put it in real time and make the correct decision. In the same way, we got the same indicators of mortality, lethality, positivity, positive results, and incidents, and we made a classification through the municipalities. No COVID municipalities, low affectation, high affectation, depending on how these indicators behaved in order to classify and make these decisions of closing a municipality or closing down an area or having other measures in order to allow to work towards this and go back to a little bit of the normality. This also helps to priority like indigenous population and foreigners, and it also achieved the georeference of the cases to identify the conglomerates. These conglomerates, via the georeference, it also was considered if it depended if they were prisoners or militants. This is the behavior of COVID-19 in Colombia. 2020, 2022, it's very much similar to the countries of the region. Some weeks it was bigger, a bigger peak, and then the duration of the peaks were very similar as well. With this information, we were able to make decisions to tune the mandatory isolation to implement isolation strategies that was selective and sustainable. It was initiated on February, the vaccination plan for COVID, and then at the end of the year, you could see all of these variants of COVID-19. We have the Delta and Omicron. We see that at the end of 2021, we have the beginning of 2022, we have a high peak due to the variant of Omicron. And then at 2022, we had other guidelines that it was not necessary to take too much samples because of the capability. We couldn't take too many samples to everyone. And here we have a great impact of the curve, especially the one we see on green on the mortality, and how this reduction took place when we began the plan. In its first stage, it was with the health workers and seniors over 80 years old. And we started prioritizing other populations, and from 60 to 70 years old, we started prioritizing them afterwards, and then we did the booster shots. As I told you, at the end of 2021, we increased the incidence, and we saw how the mortality clearly increased, but not in such a big way as in the previous peaks. Currently, we published the information not anymore daily but weekly through the epidemiological weekly bulletin. And the dashboards are in the SysVigila portal, or you can check out the epidemiological bulletin, and not only the COVID information, but all of the events we make a publishing document that it's annually. We have other one that it's every 6 months, or different events that are prevalent. And I truly like to research the region, so I invite you to research our websites and our bulletins, because it's good to see how we are doing with measles, how are we doing with flaccid paralysis, these types of events that are the ones that are most at risk in our region. And to finish, this articulation with the different institutions truly helped to generate information in order to make decisions. It is very important to consider that we need to keep going with surveillance and detection on COVID-19, but it's also important that the diagnostic that COVID-19 left us, it's very important for us to consider in other events, in pertussis or diphtheria. This truly can easily be diagnosed with these samples and tests, and you don't need to send a sample up until to the national lab. You can do that in real time. This is all I wanted to tell you, and thank you so much. Thank you so much, Sandra. Now we call Juan Pablo Rodríguez. Hi, good morning, everybody. It is a pleasure to be here in this very important conference presenting the advances of my countries in the cold chain. We have 4,300 kilometers, and we have on the north the worst desert in the world, and then on the south we have the Antarctic of Chile, and we have a very cold weather there, very hot on the other side. Without a doubt, this is a big challenge for the maintenance and the assurance of the cold chain throughout our supply chain. So administratively, we have three levels on the cold chain. Central level for the immunization department. Main function has to do with the import of vaccines, and leave it to an intermediate level, making sure that you ensure the cold chain, and we establish the regulatory policies for the whole country regarding these matters. The intermediate level has 26 deposits of vaccines, and its main function is to provide assurance to the cold chain when it's being reserved regionally. In some cases, also to the transportation towards the health services. Locally, we have 2,500 vaccination centers, and during the vaccination campaigns, it could be even to over. It can augment into over 5,000 vaccination centers. They have the main responsibility to make sure that the cold chain is working in the last stages of transportation and storage in our supply chain. The strengthening of the cold chain in Chile, mainly it's based in the intermediate and local level. In the intermediate level, around 2009, we have the pandemic, 2019, and when we have influenza, we have a big difficulty in order to reach with the vaccines throughout our territory. Then in 2010, we created 26 deposits of vaccines that were distributed throughout our territory nationally with the presence in the 36 regions of our country. Since we created this establishment have telemetrics and monitorings remotely. It helps us with traceabilities of the temperatures, but it also helps us to control at a central level the functioning of the critical systems of our cold chambers. Then in 2018, we started working in the assurance of the quality of our processes. Then in 2018, we certified in ISO 9000 in purchase, procurement, reception, and the stock of vaccines in the regional reserves. In 2019, and before the start of the pandemic of COVID-19, we had a prequalification in the operation and the performance all of our storage units nationally. In 2020, we published 12 SOPs that mandated the deposit of the vaccines since you receive a product until you deliver it into a health facility and all of the processes that need to keep it. This truly strengthened the management that we have regionally. Since 2020, after 10 years of this establishment's been working efficiently nationally, we have a new investment of resources in order to extend and amplify our capabilities of storage that we needed because of the COVID-19 vaccines. Now we expanded and improved 16 of these investments and we invested $5 million. We foresee that to 2025, we're an investment of $9 million. We are going to comply with 100% of our structure of our reserves. As we have seen in this conference, continuous training, it's an important role. So since 2020, we have a course of continuous training that is targeting all of the intermediate level health workers, 100 people that are working in these reserves. And we have two courses that are centered in the regulatory framework of our country. In another line, we have everything that had to do with the SOPs. Let's see the strengthening in the local level. It was accelerated with COVID. This was a big challenge in our strategic planning. First, we wanted to strengthen the intermediate level, and then we were going to go locally. But then COVID arrived, and we needed to accelerate the strengthening of the cold chain in the execution level. Our main challenge was to handle vaccines that had zero studies of thermal stability. It made it very hard to store and transport in this last mile of the cold chain and supply chain. We worked in the design and the configuration of 3 types of passive isothermic containers with a capability of 15, 35, and 70 liters for transportation. These isothermic passive containers were designed by us and a private company in Chile. We had a mold in Spain and now it's in Chile, and we created mass production of this containers at a low cost, and we was very efficient to transport the vaccines. These containers also had our commitment to lower our carbon footprint. They contain 30% of recyclable materials in their composition. Additionally, to incorporating recyclable materials, We standardized the units that we have in the refrigerators. Before, they were disposable at that time, and it created a lot of waste. But now, with a purchase with PAHO, we have thousands of units that we truly diminish the risk of freezing with the standardization of our cooling units, and it truly helps because they are not disposable anymore. In another line, we have the incorporation of thermal units in order to have a traceability of the temperatures. In Chile, we use alcohol thermometers that was not precise before. So when we incorporated this machine that you see at first image, it truly helped to close a gap in the digital part, and we needed to provide training for them to use it. We also donated clinical refrigerators into different establishments, and we created a different projects for investment so the municipalities and the localities could have new clinical refrigerators. Lastly, this is news that I'm going to tell you because before the TechNet, we have the new regulatory framework for the cold chain for executor level that it actually gathers all of the learning that we had in the pandemic, and we have put it into an SOP. And when we get to Chile, we need to work truly hard in implementing these new SOPs. Without a doubt, the pandemic gave us so many lessons learned. The first one and the harder to accept is that the cold chain goes further than refrigeration. Before COVID-19, we were very well prepared to transport and store into 2 and 8 degrees. But with PAHO, we have more than 1.5 meters, cubic meters for refrigerators throughout our country. And we also implemented 20 ultra freezer clinical refrigerators that were distributed strategically throughout our territories. The traceability of temperature had a very important part in the process of the pandemic. When we incorporated the machine for taking the temperature, we had a lot of exclusion of temperatures that we were blindsided about on local levels. And through the analysis of the excursions of temperature that we have on the central level through the use of these machines, we were able to free $7 million in vaccines. Lastly, qualified transportation has truly delivered efficiency and security in our logistics operations. Security because these are qualified to 24 hours, even with external 35 degrees Celsius and temperatures on the external side. But this work that we did internally, we can access these containers from $10 to $50 each. And of course, as I told you, it's very important to us that we're able to diminish our carbon footprints because they are made with recyclable materials in the design of these containers, and we have standardized the refrigerator units that nowadays in Chile we can see them, and it's coming in a new regulatory frame. This type of units are going to be mentioned there. Lastly, but not least important, this is an invitation to all of you. The regulatory frameworks and the norms that we have from the Ministry of Health, they need to be framed in a process of continuous improvement. We cannot wait for technology to go further than our SOPs. This is why we incorporated all of our processes through the ISO 9001, 9015, and we are being updated with technology and the new vaccines that are coming. Throughout this conference, we have talked about the importance of the cold chain, but this is a very much important message. Without a cold chain, we do not have immunization. Thank you so much. Thank you, Juan Pablo. These were three amazing presentations. Let's open the floor for some questions. If you can raise your hand, we're gonna grab the questions in Spanish so we can prepare our panelists, and then we're gonna take some English questions, English speaking questions. If we have English questions, let's prepare our panelists with their headphones. Go ahead.
From Turkey. for your presentations, Thayssa, Pablo, and Sandra. Thank you also for you, Nora. You do very well jobs in Ministry of Health basis, especially Brazil is a very big country and more population, with more population also some problems with Chile. It's very difficult to reach all the regions in a short time. In the future, I hope our country and your countries may be in collaboration. But one more specific questions. These are our wishes for Sandra. After the third dose of COVID vaccines, you immunized 65 years old, the third dose. After the immunization, is there any effect that changed the incidence or mortality range? Thank you.
Without a doubt, we did have a decrease in the incidence in this population, but it's still the one that are most affected. Our seniors that are above are even 70 years. Unfortunately, they are the most affected ones. We had a decrease, of course, but they're still the ones that are most affected. Any other questions?
Chile. The cold boxes, the design which we saw, was it?
Can you speak a little bit louder?
Sorry. My question is to the gentleman from Chile. The cold boxes which you designed, were they following WHO standards and were they pre-qualified against WHO standards?
Bien.
Thank you so much for your question. I was talking precisely with Analcia that Chile has standards of qualification that are their own. They come from our Institute of Health, that is our regulatory body in our country. They go very well with the pre-qualifications of the WHO. I think that they have the same components. So in our country, because we have this norm, we were obliged to comply with those standards of qualification. I'm happy to share them with you, and we can keep strengthening our line of work, and we can have a joint effort and joint work gladly. We have another question. This is in Spanish. And then another question, right? Hi, can you hear me? Yes. I'm from Argentina, and I'm wondering, Juan Pablo, Chile. I'm in a neighborhood country with very much the same characteristics. How did you handle in Chile with the training of the personnel? Did you have a base or fundamentals to reach that everybody that was a vaccinator in Chile or worked with vaccines were trained in the cold chain? Because this is a big challenge. So we want to take those lessons learned as well, even how you're dealing with it right now. Thank you so much for that question. Effectively training, it's a part of our Achilles heel there. These technical and these technological gaps and the use of this new pre-qualified box that has a predestined configuration, it is out of the knowledge of the people who are transporting the vaccines. That was a big challenge in order to standardize our processes. When we have a standardization of processes, we need to go hand in hand with a very robust training plan. With the cold chain and the immunization program, we have 4 people that work truly hard in these lines of work. And for example, for this new regulatory framework and the execution levels that I told you that I proudly we published on October 12th, our new regulatory framework, we have a plan of training that is fortified by online annual trainings. They are in a website always of the Ministry of Health that is destined to generate more interactive courses and new technology based on new technology. And it's not only a presentation through the internet, but it's very much interactive. This allows us to reach every national territory and everybody with mass trainings, but we share this with visits to all of the regions and regional seminars. So we have a lot of strategic lines to go ahead and close this gap on training. But the one that is the mass one is the online, but we also accompanied it with visits to the regions and, face-to-face solving any problems, any hesitations, questions with the regional and ministerial secretariat and the health centers, everybody that is in our sanitary system. I want to say something here because it's very much important, the training of the health personnel that actually they come and go, but we need to do supervision. Supervision is key because yes, you're trained, but you need to supervise that is being complied and the norms and regulations and SOPs are being accomplished. We had another question. Hi, good morning. Thank you for all of the panelists. My question to Juan Pablo, can you tell us about the monitoring system of the machines, the new ones that you use now to take your temperature, thermographs? Do you use a technology that it's external or do you have internal technology? Thank you for that question. The monitoring system, I was talking about this with Nora. We had a several variety of technologies that we have developed here in the visits that I was able to do through the coffee breaks. There were a lot of things here that we were creating that were already created here. And this is an invitation for all of the countries to please let's talk, let's have a conversation, let's improve our processes together. So our monitoring systems that exist since 2010 and our cold rooms or cold chambers are in a software where we can have a visibility of the 26 deposits of vaccines. That is all we have. We don't have remote monitoring on locally. That is something we're working on. This is a huge challenge because I was telling you that it's 2,500 sites. And in campaigns, you can get up until 5,000, right? So, nevertheless, we have a lot of technology now. I believe that we don't need to invent the wheel right now. There are a lot of systems that are designed and they are high quality and they can truly contribute to close that gap in every country. And they are available through the catalogs of PAHO. And with the thermographs, specifically, we have a norm that is very important. We require that the purchase of thermographs have a calibration that it's traceable at a NIST pattern, or they can be calibrated by recognized companies by our standardization institute. We need a calibration that needs to be validated nationally or at least internationally, recognized by a company that needs to be prestigious at least, you know. We had another question. I don't see any more hands raised, but I believe that these were amazing experiences, excellent presentations. It was amazing to share with all of you. Now that we're here in the Americas, I see familiar faces, people outside of the Americas. It's so good to have you here, but we truly want to thank the panelists. Excellent presentations. Thank you so much. Let's give them a round of applause. And to all of you, thank you for joining us. Thank you.